Hey everyone, welcome to our session on finessing feedback. My name is Serena Dash and I'm one of the APDs at Duke University. I'm joined today with my wonderful colleagues, Dr. Mike Gottlieb and also Dr. Kasha Gore from Rush University. And we're excited to share with you today some tips and tricks on really how to create a culture of feedback at your home institution. And of course, we have no disclosures to mention today. So we really want to help you to build a culture of feedback, but as you know, there's so many components involved in doing so, but really the foundation of feedback is really establishing expectations. So I think we've all experienced this before, right? We're getting feedback on areas that we didn't even know we're being evaluated on, right? But you can actually help change the culture by breaking the cycle. So the first step is to set goals together. So the key is that even before the session, right before you show up to your shift, it's important to identify with the individual what those goals are going to be, and then also just to reassess those throughout the shift. So before I start a shift, I go to my learners, ask them to commit to just give me one thing, right? One thing that you really want to work on during this shift, so I can really focus my attention on that. And it's up to them to choose what it is, throughput, efficiency. Maybe they want to work on the verbal presentations for my interns or their differential diagnosis. Anything that can really make them a better doctor. For my seniors, I usually tell them they get to pretend to be attending this shift and I get to check out and let them take over, right? But really working together with that shared model of what that goal is going to be is really helpful. Also using feedback cards has been shown to actually help improve this goal setting and incorporate feedback a little bit better into that culture as well. The next step is kind of building on the first. Is really, having this shared model of what you want to accomplish. Now, we do this all the time, right? In patient care, when we're running codes, we make sure everyone's on the same page. We also need to make this a natural approach to when we're giving feedback as well. So we need to align our goals with the learner's goals, and it can really help to give as well as to receive feedback. So that shared mental model is really essential for the buy-in as well as the collaboration. So an example would be like, okay, Mike, you aren't really sure what you want to work on today, so why don't we focus on, developing your differential diagnosis? I'll give you direct feedback on that if that sounds okay. And then he could tell me if that sounds good, or he could be like, Sri, I'm already good with that. Let's do this, right? So it kind of helps us to get on the same page of what we're focusing on. The next is really, as much as we love teaching everything to our students when they show up on shift, we really need to do this also with feedback, is we need to limit the amount of feedback we're going to give, right? So it's really important to create a tailored action plan based on those goals that you created. This can really help you to monitor and evaluate your learners' progression as well, too. Another idea is really creating a common language to empower your faculty to give feedback, especially, that constructive feedback that we're all afraid to give. So, regular training sessions is going to be really key. And, the way that we do it is that we actually tie it to when the faculty has to be there, like right before our, faculty meeting, so that we'll have the most kind of turnout as well. And then also letting them know, this is the common language that we're talking about, with milestones, so that they know that our interns are not actually at a level 5 where they're making, systemic changes, but they're actually supposed to be in that 1 to 2 level, and that's okay. So really kind of getting them involved in the competencies and what that means can really be helpful. And then kind of finally in establishing expectations is really figure out, how to do this in the ED. So, we all know with the variable workflows, the acuity, the competing commitments, teaching as well as giving feedback is really a challenge. So, having those limited numbers of well-aligned goals can really help you as an educator focus the period of observation on that specific component. And it really shortens the time requirement as well as allows you to make direct observation much more feasible. And so the way that you can do this is really incorporating this into your workflow. So maybe the last 10 to 15 minutes of your shift, you can say, we're going to give feedback during this time, come find me, or I'm going to come find you. So it just becomes part of your regular workflow. So that's really a great way to kind of make it part of the day-to-day norm. So Michael, what are some other ways that you can think about finessing feedback when you're busy in the ED?
Thanks, Sri. So it's important to be giving feedback both throughout the shift as well as summative at the end. Sometimes we envision feedback as this, it must be at the end of the shift, but oftentimes we're doing it throughout the course of the shift as well. And in fact, if we wait until the end, we don't really give them an opportunity to actually incorporate this in practice or assess how they incorporated this. If we save it to the end, then it's stuck with the next physician taking care of them or working with them to figure out, did they incorporate that? And they don't have the context that we do. So we missed the opportunity to actually give sequential feedback and see and kind of refine that over the course of the shift. And then, as Sri mentioned, try to set the expectation at the start of the shift that I'm going to give feedback throughout the shift, and this is kind of how we're going to structure it there. Moreover, studies have found that feedback in general is most effective when it's given in the moment. You want to give it as close and as timely as possible. The more you stretch it out, the more that moment is gone, and the less it ties to an actual experience and makes it less memorable and less likely to be incorporated. And so one way I like to do this is I'll bring it into every patient encounter. So after we do the patient, we talk about the patient and the plan, is I'll link in my feedback to that specific encounter. So again, it ties back to something more tangible, and it's more timely than trying to, again, wait several patients later. Another way that you can incorporate, or another maybe consideration to have in here, is when we think about feedback, our minds often go towards this negative tangent that all feedback must be areas for improvement. And yes, that's a part of it, but also there's areas that people are doing well that they need to just be amplified up to let's do more of that. So not all feedback needs to be negative. I try to actually get a pretty healthy balance of things that they can improve upon, but also things that they did well that do more of. Because if we don't highlight the things they need to do more of, that's going to go away. So we also have to identify what they do well and try to lift that up and try to give them some confidence and reinforce these positive behaviors. Now, numerous studies have also shown that learners and educators don't often agree on either when or how feedback should be given. And a simple way to do this is just signpost it. You could say, for example, Kasha, I'd like to give you some feedback. Then you pause. So it actually sinks in like this is going to happen. Because if you don't say it, oftentimes we give feedback and the learner doesn't recognize it, which means either that we're not being clear enough with that, or if the learner's not receiving it, that even if we're giving them feedback, they're not going to interpret it as such, and they're not going to ingrain it the same way. And finally, if we're going to give feedback, we have to be conscious of our environment. Small pieces of feedback and like micro changes into their plans, that's probably fine in an open environment and may actually be beneficial as you bring in teaching points. But when it's larger pieces of feedback, whether they're more personal or whether they're more summative in nature, those should be separated off in a safer area, generally away from other clinicians, from patients, from other staff. Because if the learner doesn't feel safe, they're not going to be in a state to actually be receptive to it, and we really miss that opportunity to get feedback. So I'll pass along to Kasha here.
You did a great job, Mike. Just make sure that you keep reading. I'm just kidding, but seriously, how many times have our residents heard that kind of feedback? And what exactly are they supposed to do with it? This kind of feedback leaves really no room for growth or guidance to the learner. If I wanted to be more specific, I could have said something like, hey, Mike, I wanted to give you some feedback on your presentation. I thought your talking points were really well laid out and presented at a good pace. And I really like to use examples as it helps the learner kind of conceptualize the message. So while providing specific clinical feedback might seem challenging at times, if we utilize some of the advice that Mike and Sri just mentioned, it can feel less overwhelming. So for instance, going back to those aligned goals that we set at the beginning of the shift, doing that throughout the shift, you can keep track and give feedback that's specific to the learner. And I personally actually write down these goals on my patient sheets so that I remember to go back to them. And in order for this to work, I do encourage my residents to avoid broad goals like I want to work on communication, and instead ask them to focus on a very specific aspect. So if they were just told I use too much medical jargon in my communication, maybe that's something that they can actively work on this shift. Furthermore, familiarizing yourself and your faculty with the ACGME milestones and expected resident progression can also help facilitate more specific discussions. And then finally, giving feedback that's timely and labeled can really give you very particular encounters that you can come back to, and that resident can recognize what exactly that they did poorly or well during that shift. Another really useful way to provide specific feedback is by doing it on direct observations. So actually taking some time and then following the resident into the patient room and observing their encounter. And doing this allows you to take the focus off the individual and instead put it on a specific event. And being able to frame it in relation to an event rather than personal characteristics can help feedback be more receptive and accepted. And this also helps us avoid any biases that we may hold. And Shree's going to talk about that in just a minute. We realize that the whole shift can't realistically be filled with you following residents around every room, but this tool particularly can be helpful when residents are struggling with interpersonal communication skills, or if I'm having trouble identifying when a resident is struggling with a specific area of collecting data or synthesizing data.
I totally agree, Kasha. I think, one of the crucial components of feedback and feedback culture as well is this relationship you have to establish with respect and trust. But a lot of things can actually affect that learner's responsiveness to feedback. And some of this may sound familiar to you as well, because I think we all struggled with this during residency and maybe even still now, right? Is, previous experiences, maybe that fear of appearing incompetent, maybe even just the, biases in cognitive reasoning. But all of those really can affect how they actually receive feedback. And so we as educators really need to be cognizant of this and then tailor that feedback that we give to the learner's readiness to receive it. Also the other part is that, we can foster trust by really giving the gift of vulnerability to our learners. We could teach residents, that we as, attendings were not perfect, right? And often just giving them that idea of growth mindset is really important. And then also what this means is that, at emotionally charged times, we really need to be the one to recognize that we need to intentionally delay feedback to allow the learners some, space and time to actually reflect and then go to that private area that Mike was mentioning to really talk about it later on. Now, the other part of this is, in establishing that trust and respect is really, being aware of our own biases that we have that get incorporated into feedback. So there's lots of studies out there, unfortunately, that have found that, female emergency medicine residents, receive less consistent feedback from attending physicians than their male counterparts. And it's particularly in regards to personality traits in emergency medicine. And then this discrepancy can also be seen in race as well. So let's look at the data. And this is also included in our handout at the very end as well, too. But, here's a chart that is based on the common kind of differences in terminology used in women and male evaluations. And so you can see the qualitative comments that are actually put there as well too. And I was actually looking at this with my 12-year-old who was very upset about the terminology. But you see that, men are often kind of described as, maybe like standouts or related to their abilities, even with the emphasis of more like scientific, like research or professionalism. They also have found that male letters tend to be longer than females. And then for women, it's 7 times more likely to actually talk about their personal lives than the males. And then some of this terminology about empathetic and compassion, while it sounds really great, it actually can just perpetuate some of the stereotypes that are there with the two groups. And then, of course, this also still carries out, unfortunately, across race as well, too, for our underrepresented medicine or URM applicants as well. And so we really need to be, aware of the words and phrasing that we're using when we're evaluating our learners, because we really can change the culture by being mindful of that. So as facilitators, that self-awareness is really key to, making it an approachable and inclusive environment for everyone and to allow for this non-judgmental learning experience. And then kind of the last tip that I'll give you is, we should really establish a positive learning culture and environment. Having that positive culture can really allow credibility in the eye of the learner and then really assist him and her into receiving the actual feedback.
Thanks, Reese. So we talked about all these strategies for delivering the feedback, but if the learner doesn't incorporate it, well, then it's all kind of a waste. So we need to step back and see feedback as more of a conversation rather than this unidirectional delivery of information. It should be a shared conversation, or what's often referred to as the educational alliance, that you're working together to try to, both deliver and receive feedback. And so part of this has to do with just meeting our learners where they're at. As Sri had mentioned earlier, trying to set these goals and ensuring they actually align together. Identify what's meaningful for them. Because if it's not meaningful for them, then it's probably gonna be less likely to be received. And you really wanna get them invested early. We also need to encourage them to have a growth mindset. And part of this is just normalizing that we don't know everything, that we're constantly learning, that we have our own areas we're working on. And data has shown that residents are more receptive to feedback when they trust the actual person on the other end of it, when they see them as not this, what was effectively a talking head, but someone that's a human person that has flaws and needs to improve. they are more likely to actually incorporate this feedback. Now, one of my favorite books for this is the book, or resource for this really, is the book Thanks for the Feedback by Stone and Keen. And when they talk about how to incorporate feedback into your practice, they talk about 3 different types of triggers or things that prevent you from incorporating feedback. And so knowledge of this, I think, is helpful for us and for our learners. The first one is the truth trigger. And this is the inability of the recipient of the feedback to actually believe the feedback's correct. For example, the learner, if they're told, you need to work more on communication, they might say, well, that was just a unique situation. They just happen to see one case. This doesn't reflect my actual experiences. And they shrug it off and they say, you know what? They didn't really understand what happened. That wasn't the truth of the matter. And instead, trying to say, you know what? It might not be the overall arching truth, but in that instance, it was. So let's dissect out what occurred in that, and actually challenging us to give more specific feedback rather than you need to work on communication is, I noticed in this interaction, this occurred, and I perceived it this way, and talking it through. The next one is the relationship trigger. And this stems from the idea that if there isn't a good relationship between the feedback giver and recipient, they're not going to incorporate. They don't earn that credibility as the feedback giver, such that the recipient's going to give of themselves to actually incorporate these feedback. And again, part of this goes back to establishing trust and truth early, being comfortable with this, and having this bidirectional conversation. But the other piece of that is having bidirectional conversations such that we're also seeking out feedback. And we make that known from the beginning that we want to also seek out feedback. So they realize that this is really meant as an opportunity for them to deliver and receive feedback, and it makes it a little bit more normalized and comfortable. The last one is identity trigger. And this is the sense of when you give, and we've all probably experienced this, when you receive feedback, and you can sometimes feel like it's an internal attack against you as opposed to an event. And it's just being careful to separate out, this is an event and this is what I saw, and it's not a reflection on you, but it's an area that we can improve upon. And so separating out that event from the person is really helpful to make sure people actually receive it. And finally, we just need to be aware of the concept of imposter syndrome. It weighs heavily on the impact of feedback. If you're not comfortable in your own skin, which I think we all suffer from degrees of imposter syndrome at various times, and that carries forward the majority of us to some degree throughout our entire careers, being conscious of that impact on feedback, and at least to some degree trying to be aware of that. And some simple ways of doing that is just incorporating some positive feedback. These are things you do really well. And so it's not just all negative, it's things to amplify as well. And that sometimes helps to combat that. So with all that in mind, Kasha, how do we incorporate this to create a culture of feedback?
Thanks, Mike. Actually, creating a culture of feedback really kind of starts with cloning you and Shri, but let's start with some more feasible solutions. When we talk about cultural shifts, these are things that generally involve many players at many levels and really occur over time. There's no quick overnight fix to transitioning to an environment that supports feedback. But we're going to start with creating a culture of feedback really relies heavily on having support from your leadership and your institution. In order to have resident and faculty buy-in, constructive feedback needs to be normalized across the whole system. It needs to be an expectation rather than an exception. And it's best done with a system that's regular and bidirectional and encompasses feedback to the leadership as well. Next, feedback needs to be prioritized by supporting things like learner and educator development sessions and considering financial incentives for completion of sessions as well as for participation in regular feedback. And in order to help exemplify the importance of these things, it's important to advertise these expectations in things like mission statements and curriculum documents. This is going to ensure that these expectations are expressed outwardly to all your current and prospective employees and trainees. And finally, while this all may seem really overwhelming and difficult, it's important to kind of start at the micro level and think macro. So start at your departmental level, but then aim to involve the GME at your institution, as well as work with programs within the institution to help ensure consistency for all learners and educators. Thank you everyone for listening. And in summary, we know that feedback is critical for all of our learners to succeed, but creating that culture of feedback takes effort, and it should be targeted at multiple levels, from the learner to all the way up to the institution. And we hope some of the strategies that we discussed can help you develop and enhance the culture of feedback at your program. And if you would like to learn some more, please go ahead and click on that QR code at the bottom of the screen. Scan it with your phone. And at this point, we'd love to welcome any questions.
I'll ask a question. Thank you all for this talk. My name is Danielle Miller. I'm the Medical Education Scholarship Fellow at Stanford. I'm gonna ask a hard question, but I want to hear your input. I think like you were talking about how like research shows that like trust is like integral to giving feedback. And so my question is always then, like, how do we overcome issues in emergency medicine of trust when you're working with like over 60 residents, or like you might only work with a resident once or twice, you know, like every few months. I wondered if there was any research in like, can we establish like just-in-time trust so that we can give more credible feedback?
So I'm not aware of specific research into that within EM, but that definitely is a whole field of study that would be incredibly interesting. How I do it, and this is my N of 1, is I just said at the tone at the beginning of the shift, and I kind of normalize the fact that, you know, we're here to learn, and that's part of it. I normalize the fact that I'm human and I can make errors, and we should talk through those. And if there's something I say that differs from someone else, let's discuss why that differs and the evidence behind it and learn together. And so I try to normalize that in the beginning of the shift, and that, at least for me, has worked pretty well in creating a culture where there's vulnerability and we're okay with that, because we all know that, because we know together that we're all learning, and that's okay. And that seemed to work well, and I haven't had any markdowns on my knowledge skills in the end of shift eval, so that's good.
I can speak to that because I see Mike's evals. He does a fantastic job. I think the other part of it is too, the whole trust piece is just the way that feedback is delivered in. You can really break down trust by delivering feedback poorly. And I think gaining the perspective of the resident is a really key portion to that delivery of feedback. Because if you start off with assumptions and tell that resident, hey, you did this poorly, without really engaging them and understanding what their perspective is on the whole situation, that shuts down the conversation really quickly, and it shuts down that trust really quickly. So I think that the delivery of feedback is also very critical, in addition to setting those expectations at the beginning of the shift.
I was just mentioning, you know, to change the culture is really kind of educating your faculty member, right? So you could think about doing like faculty development sessions, even just on like imposter syndrome, right? So they can remember what it was like when they were a resident, getting good or bad feedback, right? And kind of reflecting on that is helpful, even on like the growth mindset and how to, you know, allow themselves to be vulnerable during the shift. And even just those tips and tricks on like, here are some pro tips on how to give constructive feedback, right? Or how to, those things can definitely help to start setting the standard of the culture at your institution, and by kind of targeting the people who are giving the feedback during the shift and helping to build that relationship. And any other questions? I think we're probably over time, but
You're 4 minutes over.
awesome. Okay. Well, thank
Not
you guys
bad.
so much. Yeah, thank you so much for joining us. We appreciate it.
Thank you very much.